So hello everyone. So today we are going to talk about a very important topic for your exam, which is the metastatic RCC. We are going to talk about the important updates in the EAU 2024 and understand what are the changes there compared to the last year. Okay, and mainly we're going to focus on the management of the metastatic RCC. Okay, so to begin with, what is important is the 4 points. Whenever there is a patient of metastatic RCC, you need to revolve your discussion around 4 important things. Okay, whether the patient is symptomatic or not, the performance status of the patient, the risk stratification that is different from the performance status, and the metastatic burden, whether it's oligometastasis or it's a high volume metastasis. So we need to think about 4 important things always in a patient with a metastatic RCC before we plan our management. Okay. Now coming to the IMDC risk stratification, it is very important and commonly used nowadays compared to the MSKCC, which was previously used. Okay, so we are going to remember just the IMDC one, and that is the one that is even the examiners are focusing on. So what the IMDC risk stratification is, there are what are the parameters in the IMDC risk stratification. This is something which is picked up in the that we should be knowing because it's something which are practically using it every day whenever we get a patient of metastatic RCC. So what are we supposed to know in all the parameters, all the cutoff ranges on the, so how can we remember them? I know it's slightly difficult, but try to let us have some clue how to remember it. Let us remember parathyroid hormone, PTH count. Okay, let us remember it this way. PTH count. What does P stand for? Performance status. T stands for time from diagnosis to initiating the treatment. S stands for hemoglobin. Okay, PTH count. CO stands for corrected calcium. Okay, N stands for neutrophils, and T stands for thrombocytosis. Okay, that is elevated platelet count. So neutrophils and elevated platelet count, that is thrombocytosis. There are two T's. One is time from diagnosis to initiation of treatment. Other is the thrombocytosis. So try to remember this. You are supposed to know this. Okay. So P for performance status, T for time from diagnosis. So remember it, PTH, H for hemoglobin, count, corrected calcium, and neutrophils, and T, thrombocytosis. So it's very important. This is also known as Heng criteria. So if don't confuse between Heng and Motzer. MSKCC is the Motzer, M for M, okay? M is for M. So MSKCC is Motzer, IMDC is the Heng criteria. So don't just confuse them one for the other. Now, how do you risk stratify a patient? Like, you know the cutoff, so I'm not repeating it. Okay, it's very simple. Now, how do you risk stratify it? When do you say it's a favorable risk? When there is a zero, like all the risk factors are negative. The patient has a good performance status more than 80%. The time from diagnosis to initiation of treatment is more than 12 months, more than a year. Okay, we'll come to this. Hemoglobin is good. Okay, all the parameters are satisfied and he's falling into zero. And if 1 to 2, then it is favorable. Okay, and what is poor risk? There are 3 to 6 risk factors present. It is a poor risk. So we should be knowing about the risk stratification, how to risk stratify a patient, because the management differs. Now coming to this favorable risk ones, okay, it's very difficult to find a patient with a favorable risk. Why? Because of the second parameter, okay? Because of the second parameter, that is the time. So if a patient who present to you with a metastatic RCC, so you initiate the treatment within 12 months always. So you always give a 1 score for that, and the patient comes into the intermediate risk. It is always, time is always less than 12 months. So most of the patient falls into intermediate risk by default, at least. Okay. So when the patients falls under favorable risk. So these are those patients which either have undergone a radical or a partial nephrectomy 1 year back, and during follow-up, they developed a metastasis. Then you would call a time from diagnosis to initiation of treatment more than 12 months. Or a patient on active surveillance, you give the patient on active surveillance, and unfortunately after 12 months, the patient developed a METS. Okay. Now, if this criteria becomes more than 12 months, the second criteria, then you give a 0 score. Okay. Then you give a 0 score. And then only you label the patient as a favorable risk, provided the other parameters are also above the cutoff. Okay, so this you have to remember that favorable patients are very rare to find. The other two criteria are commonly found, so we should know how to put them into the risk. Why? Because of the survival is different. When you counsel the patient for a favorable risk, the survival is around 3 to 4 years, okay? But when it comes to the poor risk, it is less than a year. So this we should know the survival. Now, okay, coming to this. So if we remember, the IMDC, they're asking, they have given you the performance status, they have given you the time from diagnosis, they have given you the hemoglobin. So they have given you the PTH. So we need to know the count, okay? So what are the things we need to know? The corrected calcium, the neutrophils, and the thrombocytosis. So pick up the question if you pick up this, then this is the answer, okay? So it's very easy if you remember it this way, and you don't confuse with the MSKCC where there is an LDH. So try to remember this. There are 6 parameters, and this will help you to recall before your exams. Now coming to this, okay, how do we manage it? Now it's very important. Regarding management, we should know which patients should undergo cytoreductive nephrectomy and which patients should undergo systemic therapy. Okay, so there are 2 treatment options. Okay, either a systemic therapy or a cytoreductive nephrectomy. Now, try to understand, whenever there is a poor risk patient, we never offer the patient upfront cytoreductive nephrectomy usually. Okay, we are not offering the patient upfront cytoreductive. We straightforward offer the patient systemic therapy. Okay, systemic therapy, we'll talk about it. We are not talking about chemo, we are talking about the immunotherapies. We'll talk about it. Now, for the timing, try to understand the poor risk patients, we are offering systemic therapy. What about the good and the intermediate risk? So when it comes to the intermediate risk or the good risk, what are we concerned about is whether the patient is having, so we again look at the symptoms, okay? If the patient has symptoms and if the patient has low volume of mets, okay, there is oligometastasis. The patient has symptom, the patient has low volume of mets, and the performance status is good. All these patients, you offer cytoreductive nephrectomy. Okay, so if the patient is, so try to understand this terminologies. Now, if you look at this, immediate cytoreductive nephrectomy is to be performed in patient with good performance status. Immediate cytoreductive nephrectomy is to be performed with patient with oligometastasis. Okay, so we are already done with this too. Along with this, if you look at the second point, do not perform patients who are asymptomatic. Don't go for cytoreductive nephrectomy upfront. If the patient is symptomatic, go for it. So try to again summarize it. Cytoreductive nephrectomy. So if the patient has symptoms, it's better to offer them. If the patient, provided those patients have low volume of mets, provided the patient has a good performance status. Good performance status is different from good risk. Okay, performance status means the performance of the patient, how he's able to tolerate the surgery and all. So try to understand these are the 3 conditions where we offer cytoreductive nephrectomy upfront. Now, all of the scenarios, if the high volume of metastasis is present, if the patient is asymptomatic, or if the patient is having a bad performance status, okay, those patients you offer systemic therapy followed by deferred cytoreductive nephrectomy. Now, how do you decide after a systemic therapy, the patient should receive a cytoreductive nephrectomy or not? This is only based on this, that you offered a delayed cytoreductive nephrectomy, only the patient has responded to systemic therapy. So this is important. We should know how do we manage which are the patients you offer cytoreductive nephrectomy, which are the patients you offer systemic therapy. Why the systemic therapy has become so much important? Why are we offering a systemic therapy before a cytoreductive nephrectomy in so many patients? What is the reason behind it? We'll come to the evidence for it. Now let us try to understand the first line systemic therapy. Okay. So if you're offering a systemic therapy, what is the first line therapy? So this is for the 2023 EAU, and this is the 2024. What is the change? We can appreciate that the first line therapy, the standard of care has been combination therapy. Okay, these are the combinations of immunotherapy with the TKIs. Okay, and still that is prevalent, immunotherapy plus a TKI. So this combination is still there, but why the sunitinib and pazopanib, which were alternatives, have now been included into the standard of care? The sunitinib and pazopanib have now become one of the standard of care compared to the immunotherapy and TKI. They were kept as alternatives till last year. Now they have included in the standard of care. We'll come to the reason. So we should know about the favorable risk, okay, the combinations. So I will come to the how to remember this, okay. So they are going to ask you this, how to remember this combinations. Before that, if you look at the intermediate and poor risk, then apart from the IOT plus TKI combination, here we are also offering IO plus IO, that is immunotherapy plus an immunotherapy combination, that is also offered in the intermediate and poor risk, not in the favorable risk. Okay. Now try to understand how do we remember these combinations. So you need to pay attention. You need to pay attention and please listen about the new chemo drugs. Okay, so if you pay attention and please listen to the new chemo drugs updates, you will remember it. So what do you mean by pay attention? So pay attention means pembrolizumab, axitinib. What do you mean by please listen? So it's pembrolizumab, lenvatinib. And what do you mean by new chemo? It's nivolumab and cabozantinib. So it's not difficult if you try to remember it this way. You should not confuse the combinations. You should not confuse the drugs. Okay, so this is how the combinations are given. If you forget the second word, this will even suffice. Okay, so if you just remember pay, it's pembrolizumab, axitinib. If you just remember please, it is pembrolizumab, lenvatinib. Okay, and this is new chemo is a nivolumab and cabozantinib. So try to remember these combinations. Now, why is sunitinib and pazopanib being included in the first line? This is because of this study. Okay, based on this data, they have found that if you compare the combinations with the isolated sunitinib, there is no extra overall survival improvement that you're offering. So that is the reason this was the 2023 and this is the 2024. What they have done is now they have added sunitinib and pazopanib for intermediate favorable risk, which was not there. So they have found that sunitinib pazopanib provides an equivalent overall survival compared to the combinations. So there is no point in keeping that as an alternative. Okay, so they have been kept in the first line. Now, sequencing. Suppose the patient fails to the first line. What is the second line options? So till now, the second line options were the VEGF inhibitors, which were not used previously. Suppose the patient was on axitinib, you can now consider a lenvatinib. You can now consider a sunitinib, pazopanib. So any inhibitor which was not used previously, you can use that now. But what has been changed? This is 2023. This was recommended. Now, what has in 2024 added is cabozantinib. That has now become the standard of care first line for any patient who have either received a TKI-IO combination or an IO-IO combination. This is very important that the second line standard of care is a cabozantinib. Okay, the rest is same. You should remember this drug, and there is no role of any combination immunotherapy after there is a failure of the first line. In the second line, you will never find a combination. Okay, there is no role of pay attention, please listen, new chemo. There is no role of that in the second line. You should only remember that for the first line. So this is the reason why they don't recommend a combination therapy in the second line, because of the contact-free study where they have found that if you use a combination of atezolizumab with a cabozantinib, there is no benefit compared to a cabozantinib alone. That is why we are preferring alone cabozantinib rather than a combination with an IO. Okay, IO means atezolizumab in this case. So we are only preferring cabozantinib alone rather than a combination. So this is important for us to remember. Okay, this was not there in 2023. It has been added in 24. Now, why so much emphasis on a systemic immunotherapy? So this data comes way back from the Cara trial. So if we go back to the Cara trial published in the New England Journal of Medicine in 2018, and this data suggests that the Cara trial suggests that if you give a sunitinib alone, offer sunitinib alone to a patient, it was the outcomes, the overall survival is not inferior compared to a patient who has undergone nephrectomy followed by sunitinib. Okay, so sunitinib alone was not inferior. So in the non-inferiority trial, it has found that the overall survival was 18 months versus 18 months versus 13.9 months. Okay, so 18 months in patients who receive sunitinib alone, there are fallacies for this. Okay, we are not going to detail of the limitations of this trial. Just for the time being, try to understand why Carmina, what Carmina has given us, the importance of systemic therapy upfront. That is the reason why systemic therapy, systemic immunotherapy is being preferred nowadays in patients with metastatic RCC. Now, why do we start the patient on systemic therapy and prefer a deferred cytoreductive nephrectomy? When to go for a cytoreductive nephrectomy, immediate or deferred? So we get this from the SIR time. What does SIR time means? SIR time means surgery time. Okay, so we are talking about the time of surgery. What is the best time to go for surgery, immediate or a deferred? So that is all about the SIR time. So SIR time says it's better that you go for a deferred cytoreductive nephrectomy after sunitinib rather than an immediate cytoreductive nephrectomy. And why? Because they have found a difference significant in the overall survival. Okay, the median overall survival they have found is in the deferred arm is 32 compared to 15 months in the immediate arm. So that is the reason almost double overall survival in patients with a deferred cytoreductive nephrectomy approach. Okay, they also mention that if you pre-treat the patient with a sunitinib and go for a deferred cytoreductive nephrectomy, you also know which patients are resistant to the systemic therapy, and you can plan your deferred treatment. Okay, there before you plan your deferred treatment, cytoreductive nephrectomy, you know which patients are resistant to your sunitinib. So this is the importance of this. Why systemic therapy before and why deferred surgery later on? You should know this evidence. Okay, so having understood the first line management, the second line management, and the evidence behind it, let us quickly come to the mechanism of the drugs, which is very common to you should know. So let us forget this part. Okay, just try to focus on cancer cells and the T cells. So the T cells have the receptors PD1, and the cancer cells have the receptors PDL1. Okay, the interaction of the T cells and the PDL1. So if there is an interaction between these two receptors, the PD1 and the PDL1, there is suppression of the T cells. Okay, the T cells are suppressed. There is suppression of the immunity. Okay, so these are the immune checkpoints, the PD1 and the PDL1. Okay, but if there is a combination of these two, if these two unite together, then there is a immunity suppression. So we need something to inhibit this fusion. Okay, PDL1 and PD1 inhibitors. So we have inhibitors, and for PD1 we have pembrolizumab and nivolumab. For PDL1 we have atezolizumab, avelumab, and durvalumab. So we should know this. It's important. Okay, so what are the things to be remembered here is PDL1 is present on the cancer cells. And what are the names of the PDL1? So you can remember it this way. So you can remember it that life at Dubai is awesome. Okay. So life is L1, at is atezolizumab. Okay, Dubai is durvalumab, awesome is avelumab. So whenever there is so many drugs in front of you, it's very difficult to rule out one. So try to have some alphabetical relation so that you can remember it for a long time. So PDL1, you should know the drugs anti-PDL1. Okay, the rest are pembrolizumab and nivolumab. Okay, so these two are PD1. We should inhibit the union of the PD1 and the PDL1. Okay, that suppresses the immunity of the host. So we have these inhibitors. Now, coming to the last question that we have is which one is the PD1 inhibitor? Okay, so quickly coming to PDL1 again, which we know what the L1. Life at Dubai is awesome. So these three are L1. And what about this ipilimumab? So we are left with two. What about ipilimumab? So ipilimumab is the only drug that inhibits CTLA4. Okay, you need to remember this. The one that is left is pembrolizumab or nivolumab. They are the inhibitors of PD1 receptors. So this is all about this metastatic RCC. Very brief orientation. You might go into depth of this, but for your section 1, you need to just remember these points, and you will be enough and confidently come out of the word some of the questions, and probably this helps in solving your MCQs and your single best answers. Okay, so have a good day. Thank you for your patient listening.